So part of the guidance from CDC involves PPE, and this is specific for Ebola, but would apply to any of the numerous um, viruses and other diseases that are out there that are similar to Ebola, as well as just good general infection control. Now, I violate the rule of too much stuff on a slide several times in this presentation, but this is word for word from the CDC guidance. And they have three key principles that they're looking for here. The first one involves repeated training and demonstrated competency, and specifically involved in the donning and doffing of proper PPE. The thought is that proper PPE is in most cases being worn when there's been an exposure to a healthcare worker, but it may be that it was not properly donned, or in the doffing process there's an opportunity for contamination, which can then lead to an exposure. The general principle is no exposed skin, and that there is a detailed checklist, a detailed list of steps in a sequence for donning and doffing, and that must be supervised by a trained observer. So our November fire training, as a follow-up to some of the rapidly deployed training that we did in late October, our November fire training is going to focus specifically on the PPE part of the protection procedures, and excuse me, and in particular, this use of a trained observer. So we'll have a checklist, and we'll practice this sort of process. General training points: donning and doffing PPE must be done in a stepwise way, without a great deal of hurry. Now, there's some sense of urgency on our part to get involved in the patient care, and that's reasonable, but particularly in the doffing and decon phase, that needs to be very deliberate, not under any time pressure, and in a step-by-step way. If we do this, then we're going to have maximum safety for our folks. Also, with any infection control procedure, there's major emphasis on hand washing, and the use of an alcohol-based hand rub, such as we carry in our EMS packs, will be used to clean gloved hands. And so several times in the doffing process, you'll be cleaning your gloves and then proceeding with the next step. Should there be any visible contaminant, whether that be emesis or fecal matter or whatever, visible contamination should be removed with a disinfectant wipe. Now, disinfectant wipes are a little new to our operations in the field, where we tend to use the alcohol-based hand rub or foam in the past, or in some cases with the medic units. But the EPA-registered disinfectant wipe, which is just a hospital-grade bleach wipe, is kind of added to our process here. It's going to turn out to be the thing we use most and very valuable to us. PPE must be applied in the correct order, and we'll practice that again in November fire training and repeatedly after that. And the thing is that particularly with the goggles and masks, two items that we're not particularly, we don't have it used frequently in the past. Once those are on and your hands have touched potential contaminant, then to take your hands and manipulate that PPE introduces an opportunity for a problem. Frequent disinfection of gloved hands, as I mentioned, with the alcohol-based hand rub. And then what do you do if there's a breach in your PPE? What if your gloves tear? What if for some reason you get a needle stick? In the process is that you will immediately perform an emergency decon, more or less. Now, emergency decon probably isn't the right phrase to use there, because to us that means a hose line off a fire truck and tons of water. But let's say more of an urgent decon, where you're going to disengage in patient care, if at all possible, as soon as you can, and remove the gross contaminant with bleach wipes and such. The doffing of the PPE and the decon process that's integrated into that is a slow, deliberate process under the observation of that trained observer. And this, again, is probably where some of these exposures are happening in areas where a large volume of Ebola patients are being cared for by healthcare workers, it's probably not the specific PPE that's being used. It's probably two things: the doffing, or the adjustment of those PPE items during patient care. So checklists are a good thing. Checklists, in this context, don't mean an inventory list when we're checking a truck. It means a job aid. And this is proven in healthcare to be very valuable in a number of settings, in critical care settings, in the operating room. And so it's moved into this process as well. And this trained observer functions as a coach and safety officer. And this is a dedicated individual whose sole purpose is to focus on this function of the donning, and particularly the doffing. That person will monitor and document all these procedures and provide immediate coaching and corrective instruction if something's not going right. Again, the doffing process and the decon is a slow, deliberate process, and there's almost built-in pauses in there while there's some hand washing that's going on, and during that time, the coach, the safety coach, can step in and talk about what we're going to do next. The trained observer does not go in the hot zone, stays in the warm zone. This guidance was written specifically for the healthcare worker hospital facility environment, so we kind of crossed that out but replaced it with hot zone to make it applicable to field ops. The person will be in the warm zone in high level of protection and be acting as a coach. N95 respirator is our minimum for situations where we have an infectious disease, and not specifically, we're not limited to Ebola virus, but in any infectious disease, the N95 is our minimum, and it's our standard minimum, and then we supplement that in specific cases, highly suspected Ebola patients, we supplement that with the full face respirator. Gloves, obviously single use, 2 pairs. Double gloving is the standard now, and we've got some outer gloves that have both an enhanced thickness as well as an extended cuff, so that that second glove will come up higher on the suit, and we've added taping to that process. CDC makes the comment that if you wear 2 pair of gloves, that's probably reasonable, but 4 pair of gloves may cause you enough loss of dexterity to add some danger to it. I think in the situation where you're already double gloved, and then there is copious emesis or fecal matter, that third layer of gloves may add you some protection without really messing up your dexterity for the things that we're going to do. So we're not outlawing triple gloving, but just make sure that you understand there's a trade-off there between dexterity and coverage. So what disinfectants do you use? Well, really it's not that difficult. There are a number of bleach-based products that are available hospital grade, and if they attack the viruses listed there in bold, then they will work for Ebola. There's not a specific product out there at this point that lists Ebola, but these viruses are all so similar to Ebola that we're going to go with that. And so in our case, I believe the Clorox brand hospital grade disinfectant wipes will be quite sufficient. What about spills of blood or body substances? Well, if it's in the patient care in the house, we're mostly going to move the patient to the ambulance and leave that cleanup for later. But what about in the back of the ambulance, or in an area where we just don't have any choice but to deal with it? And so the basic principle here is there's cleaning, which is essentially the removal of material, and then there's disinfectant after that. To simply pour disinfectant onto a puddle of emesis or fecal matter is going to be less effective than to simply move that material out of the way, contain it, bag it, and then do the disinfectant over the area where that was touched. In some of the CDC guidance, there were some frequently asked questions. We pulled out a few that might be of interest. And this was one that we thought was of particular interest. It seems kind of counterintuitive that if we're going to be spending all this time bagging and using highly protective equipment, what if the patient has used the toilet? Can we flush that? And the answer is yes, absolutely. That the sanitary sewers are more than adequate, which kind of leads us to the question: how long does this stuff persist? And there's a couple different studies that are out there, and the bottom line is the bottom line on this slide. It may persist up to 24 hours. That's a reasonable, cautious upper limit. It probably doesn't last any longer than that. There were ideal conditions in a study that showed the virus could remain active for up to 6 days in wet substance. And so really it's more of a 24-hour sort of thing. So that's at least the PPE portion of the recent guidance that's come out, that we need to make sure everyone has the information and is reminded of that in order to comply with what seems like pretty reasonable guidance from the CDC, and the whole checklist of items for us to cover. And this was us repeating stuff we've talked about before, as well as trying to fill in a gap or two.